chiefs of police, and Arrive Alive Drive Sober.
You're watching Rogers TV.
Well, welcome to this episode of Food Bites. You remember just a short while ago we talked to Cheryl Forchuk, who is one of my favorite guests. She's been on a lot. This will be her sixth time today. But she has been awesome at helping us to understand the homeless situation, the numbers, the fluidity of it all, so on and so forth. But there's a new paper that's been released between Cheryl and some collaborators, and fascinating. And we talked about it a couple of weeks ago, the whole idea of dementia and how that has suffered amongst homeless populations. And it's I find it fascinating, and I really feel that we need to understand it better, especially since a lot of it's taking place amongst the younger population. So I've asked Cheryl to join us, and she's here. And Richard Booth is also here, one of the folks that she worked with on the paper, which has done very well, that paper has. But Cheryl, why don't you introduce Richard to us and the role that he played in the production of this study?
Yes, well, Richard was the lead author on this paper, and he is co-PI with me on the larger homelessness count study, and a fellow nursing colleague in the School of Nursing at Western. So Richard and I have collaborated. He also has a mental health nursing background, does a lot in technology. You have to remind me of the name of the chair you have there, Richard. But I think we make a really good tag team because Richard's very good at large databases, although he also does qualitative research. But when we partner up, he's sort of taking some of that big picture pieces, and I'm dealing with some of the on the ground issues so that we can look at things very holistically. And Richard, you give your proper title.
Sure. No, I'm Richard, and I'm a faculty member at the Arthur Labatt Family School of Nursing. I hold a research chair looking at digital health innovations, and I'm a psychiatric mental health nurse by background, which I think kind of adds some context and rounds out the ability to generate work that has policy and practice implications, especially for vulnerable populations. So a good chunk of my work over the last 5 years has been looking at mental health and homelessness, along some of the other digital health work that I tend to.
Richard, I was out this morning with some folks talking about the health and homeless strategy in London and what's going on about that. But when you got into this study, obviously, I think it's a significant one. Did you just have a hunch that you were going to find what you did, or were you sure you were going to find what you did? And how did you quantify it and qualify it as you went through that process?
That's a great question. Roughly 4 years ago, I was 4 years and a month ago, sitting in Australia, finalizing this grant that was funded just before the pandemic set in and turned the world upside down. And as we were successful in that study, the Homelessness Counts study funded by the Public Health Agency of Canada, we started off really trying to contextualize modern homelessness across Canada, both in a quantitative and qualitative fashion. And on the quantitative side, we started off on a number of different projects using an algorithm, which essentially means that we had a bunch of diagnostic codes that we could query through provincial health record data to see if people had episodes or interactions with the healthcare system and had been flagged for being housing vulnerable or homeless at the time. So using that approach, we were able to identify a number of groups of individuals in Ontario at very high levels, in the tens of thousands commonly, who had had an experience of homelessness in a year. And then with some of our subsequent studies that we had kind of in the early part of the 4-year project, we started noticing over and over and over again this idea of dementia starting to pop up on our radar. Because we usually put it in as a covariate, nothing that we were actually chasing originally as a study product. And it just started loading every time with way more numbers than we had expected. And then we took a step back. We thought about, clinically from our past practice, yeah, there was actually a fair amount of individuals who were housing vulnerable with dementia. And it just became a very aha moment at that point that we saw a signal in the data that we all knew anecdotally and clinically, but never actually thought to privilege as a primary topic. So that was about 2.5 years ago, and it's kind of culminated into this paper now.
Yeah. Can I ask you, I mean, because only researchers could answer this, but how do you, I presume as you slowly move your way into it, a bias could develop, right? As you're moving into these studies, you're kind of confirming what you're thinking. How do you do your best to keep bias out of that, especially when you're discovering a lot of things that are confirming what you thought?
And that's, once again, a really great question. So the terms in research world would be like your internal validity and things like that. How did you remain neutral, especially from a quantitative sense, to keep the study design in a way that you just don't find what you find, or you just don't go, quote unquote, fishing? So what we did, once we found some preliminary insights that dementia may be something that worthwhile to look at, we prior or in advance really flesh out the actual project. We do that all in advance, put out all the codes that we're going to search, all the analytical processes. To touch provincial level data is a pretty big, sizable job. So the ICS is the institute that we work through here in Ontario, and they've been great collaborators on all our projects. And they sit within health legislation law. So we're able to query for population level health sciences research, information that's important. But there's a lot of protocols and a lot of securities, and things have to be done in advance. You just can't go into this data set and just start picking out things. So that is what keeps this on the up and transparent, because all our records are auditable, and we don't find what we want to find. We find what the numbers actually are, which is the interesting and very important kind of policy and practice outcome of these studies. Because of our rigorous methods that we have in advance, enables anyone to look back at our process and go, yes, the numbers that they found were done and delivered and derived in rigorous and transparent fashions. Does that kind of address your question?
It does. Cheryl, any thoughts on that?
Yeah, absolutely. Because it is this wide province-wide data that includes everyone in the entire province. Everyone in the province that has a health card number is in that database. So it is probably one of the most rigorous ways that you can actually approach the problem. And for people experiencing homelessness, one of the reasons we find it important, we know that a lot of the existing methods count on people touching the homeless sector, whereas the ICES data counts them touching the health sector in some way. So what we find is often missing from the homeless data nationally is your smaller communities, but you could be in a community with 100 people. And if you have a health card, you're still in ICES, the ICES data. So it actually helps reduce some of the bias that traditionally comes with homeless data, because most homeless data, I would say, has an urban-centric approach because it only includes the larger communities that actually have a homeless sector. But yeah, it doesn't mean that there aren't people in very small places also experiencing homelessness.
The food bank works a lot with homeless agencies providing food, but in the process of going out and visiting various homeless populations in that capacity, there's a bit of sometimes it's difficult getting answers from people, especially if they feel that you're prying a bit too much or whatever. Mm-hmm. But before we get to those answers, how did you determine the questions? How would you know which were the right questions to ask that might give you an indication that dementia might be present here?
So to ask the right questions, thankfully, there's been a lot of work done in a number of different illness typologies and other conditions. And drawing from the ICS work that has been done already in dementia, we had the homelessness algorithm that we had validated and published back in 2019, and taking a dementia-specific algorithm, marrying the two together, and then interrogating the provincial data set, which is what we did, was how we were able to derive the numbers that we were to pull up. So the nice thing about a lot of the ICS work that we do is there's always others doing work simultaneously in different health domains and in different conditions. So it really, this paper is an interesting collection of the intersection of dementia, homelessness, and a lot of housing issues buried within it because of the way that we were able to federate data together and to create a number that has not really been enumerated outside of Veterans Affairs data down in the United States. So we think it has some pretty important policy and practice implications for Canada because of, the provincial level, population level representation of it.
Do you find, though, maybe Cheryl, you can answer this one, that the setting actually makes a difference when you ask those questions? Because you could ask questions in one setting and ask questions in another, let's say, and they're more sensitive to maybe the people that are around them, or they're more alone and therefore they can be more frank.
Yeah. And again, when we in the more qualitative arm of the study, where we also did ask some numbers questions, such as what services did they access, how old were they the first time they were homeless, then those were done individually and really would count on establishing rapport. So when we do those interviews with people, we don't just sit down and start immediately into asking the questions. We take a few minutes. Like we have a letter of information for them to understand the study and agree to participate. But we usually just have a bit of a dialogue first to help with their comfort before launching into the questions. And it is very much like a dialogue. So I would say we don't, some groups mistrust. I would say it's not so much but there's mistrust by location, but there's some information that is more sensitive than others. So sometimes at near the beginning of the interview, once we've been talking to the people for a while, they'll actually go back and correct something they already told us. So a big one would be their involvement with the criminal justice system. Sometimes people will minimize that, but then once we've established a rapport and we're talking more, they go, "Oh, you know what? I was feeling a bit embarrassed, but I probably should, clarify some information with you." And when we do the interview, it's an interview, but we're sitting beside the person. They can see exactly what the questions are, how we're answering it, how we're filling it in. So sometimes they'll just even go flip back. You go, I wasn't feeling comfortable yet, but I can see where this information is really important for you to have accurate information. And I was embarrassed. So, I said it'd been a year since I got out, but in fact, it was last month or, whatever. They will correct it. But I would say the issues in relation to diagnosis, the main difference that we see is that with the more chronic conditions, the more multiplied chronic conditions, we find that becomes more an issue in the rural settings. Because keep in mind, when we're talking about that provincial database, it's not about us interviewing people. It's about, has a physician given this diagnosis, right? So what we find is that if you're looking at a single diagnosis, like one chronic health situation or mental health situation, there's not much difference between the rural and the urban centers, but we did find that the more combined, like, let's say you're getting up to 2, 3, 4 chronic illnesses, the more likely someone's gonna essentially decide to move to be closer to healthcare, that they'll find it's more difficult to manage their health condition in the community. So in the interviews, I would say that would probably be the biggest thing. Mental illnesses, including addiction, was almost identical across the sites, but it was the physical illness and the number of comorbidities where we were starting to see a difference. And part of it too is that, you don't have a lot of specialists in your smaller rural communities. So it may even be that some people who told us they only had one or two, it may be a matter of simply underdiagnoses. But in this case, we were looking at that single diagnosis of dementias. And we also, Richard could mention too, we brought in some dementia experts onto the team as well to help us interpret that data. And as I mentioned last time, one of the reasons I think people haven't looked at this a lot in the past is because the population of people who are homeless tends to be younger than what you would expect if you're looking for dementia. I don't know, Richard, if you wanted to add anything to that.
Would that especially be true of young people?
Well, it could be. It depends on the individuals. When you have a population level study like this, it's really hard to discern what, one or two people out of the 2 million or so that we had collectively across the entire of the study did or didn't do. But we can speak from like numerator and denominator perspective that our cohorts of the 45 to 65 individuals who experience homelessness has way higher dementia prevalence than its comparator of a house cohort. So like even into that, while, association isn't causation, it is really hard to deny some of these numbers when you're seeing it, early 10, 15, 20 years earlier than what would a house comparator have in terms of the equivalent prevalence of dementia.
I'm a layman, but that's obvious from this interview. I'm a layman, but I think that I'm really interested in policy and public policy and how it informs and shapes public policy, right? To me, that's very important. So I was, as Cheryl knows, I was a member of Parliament in Ottawa when the Great Recession happened in 2007, 2008. And those on the political side of things were in such a rush to make it look like they were doing something, right? That it was shovels in the ground within the first year and all that stuff happened. And then I met with some other city engineers a few weeks ago, and they were saying the problem now is that after the pandemic and other things that came, the feds and the province just loaded all this money into communities for sewer replacement, sidewalks, bike paths, road repair, all that kind of stuff. And because it was in such a rush, you end up with the situation like in London, where people spend their time basically cursing whenever they're in the car, right? Because you can't get from A to B without all of this problem. I think that's kind of a symbol about what happens with rushed policy. And I wonder, because communities often, they're responding to the pressure that's there and the pressure from the public and from the media. So when it's come to homelessness, it's clear that it's now front and center in the mind of communities across the country and also politicians and others. But Richard, this would probably be your field here, but how is it best then to take what you have learned around the dementia piece and get it into the political sector, the public policy sector, in a way in which it will have an impact based on evidence and everything else, not just a sudden rush to provide something? How would you do that? How would you make sure that all your ducks were in a row as you presented that, and make sure that it's well thought out before it goes? It doesn't mean that a government will therefore introduce legislation that goes along with it. I get that. But how do you pull all that together, especially in something like this that's so kind of novel? I think it shouldn't surprise us, but it does a bit, about dementia and dementia in the young population. That was a long question, sorry.
No, it's great. And I know Cheryl will have answers and responses to that too, so I'll let her follow up after. But there's really two things that I think are important coming off a study like this: appreciating where it's at, and that this type of study is possible because we have records that we can query and we can do work with to have population level insights. But when we have numbers that we all kind of knew would probably be the case, you can't deny it now. And I think that's the important part. We sometimes get critiqued, water is wet. Well, thanks for a study on that. But now you can't deny the numbers that we have, and that this cohort of the population that has largely been ignored actually exists because we've enumerated it. Because of that, I think from a policy and practice perspective, there's two implications that we see really falling out of it. First, from a clinical and practice perspective, is dementia screening needs to happen earlier. Just for homeless populations in general as just a cut and dry thing. Normally it's 65 plus in terms of the age category when people start to be screened if they have diagnostic criteria or collateral information in terms of information from family members. But we have a potentially very vulnerable cohort of people here who may not have family to talk to a family physician. So it's one of these things where earlier screening in places where individuals experiencing homelessness are, and like shelters and things like that, and hospitals, I think is something that from a practice perspective really needs to be happening. And the second part, which is it's going to stumble into a bit of Cheryl's domain, but I'm going to let her chase this, is supportive housing for very vulnerable individuals. Like, I think the way I really want to contextualize the final part of this response that I would do to any provincial, federal, or municipality is, first, you're homeless, which is a pretty big deal. And secondly, now you have cognitive deficits because you have dementia. Stick those two together. What kind of quality of life do you have? And I can pretty much say that you probably don't have much life left. The end trajectory of people in this study is very poor. And now we didn't quantify mortality because we can't for various reasons, but we all know clinically and anecdotally that these individuals have some very terrible life trajectories. And the only thing that is going to support these individuals is housing arrangements that can care for their needs. So I'll turn it over to Cheryl because I know she has ideas also.
Yeah. No, absolutely. And keep in mind that dementias such as Alzheimer's are essentially a terminal illness. It's not something that you're going to recover. You may slow down the progression, and we are seeing treatments that can slow down the progression. So that certainly needs to be addressed. And investment in public housing, supportive housing is clearly part of the solution. In some of these cases, it may even need to be access to long-term care. I totally agree, because we talked about this when we were developing the paper, that one of the main things is about the screening. And certainly the service providers in the homeless sector that I've talked to, once we were starting to do some work and identify this, they were off saying, yeah, I think I am seeing that. Or in some cases, they were sure they were seeing it, but they don't have screening tools. And that is super important. And just as a parallel example, when we were starting to, and I can't remember that this would have been when you were in office or shortly after, we were hearing about the problem of homeless veterans. You'll recall that, and we did not have good numbers or a good understanding because it wasn't a question that was asked. Right. So when we have some of the data that's collected at the shelters, that was not on the list. And I remember I was in Ottawa for a committee meeting that was related to housing and homelessness. And one of the people working for a federal agency says, well, what do you know about veterans and homelessness? And by total coincidence, this was when we had our CURA, Community University Research Alliance, and one of our focus was around employment. I had literally had a focus group the day before where people were talking about their work history, and 3 of them were veterans. And we're here in London and locally at a shelter. So I called the shelter. I said, well, how many veterans do you have? I talked to 3 of them yesterday, and they go, I didn't know we had 3 veterans, because it's not a question they asked. So I certainly said, well, yeah, I know we can do the study. I already know where 3 of them are, but so we can, but it was pure serendipity. And so one of the first things that we started doing, and which is now part of HIFIS, which is the National Data Collection System, is to ask the question. And how you ask the question is also important, similarly as it will be with dementia. And giving people, there are some really simple screening tools that we could probably some of them are more involved that would not be appropriate, but there are some simple screening questions that we could teach people to do to add so they could get some assistance, because these people are not going to just get miraculously better. They are going to get progressively worse, and how fast and how bad that happens depends on early identification and intervention. But I would say if we could do a similar thing as we did for veterans, and include it as part of the assessment, but have something like 5 questions, 10 max, that are asked, and then have a system where we would refer them with positive results for a more thorough assessment.
Yeah, it seems to me, and that's important. We've only got 5 minutes left, but it seems to me I'm also interested in the service providers, because many of them are like we are about food. Right? Like we mean well, there's lots of volunteers. They're all wanting to make a difference. And there's many faith groups, volunteer groups, and others that are helping within the homeless population.
Yep.
But they are not necessarily qualified to really judge a lot of this. So I realize that within the health and homeless part, because the health part of the sector is so involved in that, there will be a lot of what you're talking about here, both of you. But just out there within, say, the 1,000 people that are out in London that are homeless, that are living in encampments, so on and so forth, and that aren't part of that, how do the service providers themselves take this, what you have given them, because this is a tool, it's very helpful, right?
Yeah.
How do they take that and do it? Do you break that down in some kind of way for them? How does that work? I just don't know.
Well, what I would say first is that they're aware that it's an issue, but I think we need to help them a little bit further and work with some of our specialists in dementia to advise us on the best questions that could go forward. I would think, we talk about orientation to time, person, place kind of thing. Like, do you know where you are? Do you know what day it is? Like that's what we call like just those orientation questions, where if people are having struggle even with who they are, where they are, what day it is, and look at how we could link them into services. In London, you're right, because of that emphasis on health, that will be easier. But if we don't, without identifying the problem, it's hard to find a solution to the problem. And this is the first, like not only in Canada, it's the first population-based study of this, as Richard said, other than the one in the US that was purely focused on veterans and American veterans. So this is the first one in Canada. It's the first one in the world that's really a general population question on this intersection. So this isn't the end of this journey. This is saying, this is a real problem. We still have work to do to say what are some of the best strategies to address this problem. But early intervention identification's got to be a big part of that.
Richard, how do you feel about that?
No, I think Cheryl kind of summarized it very acutely. This is the first cut of a topic that we didn't plan 4 years ago to be studying, currently in April 2024. And it's one of those interesting parts of research, which unfortunately revolves around a really dark topic in many respects. But if it wasn't enumerated, we wouldn't be able to, and I use that word very, scientifically and statistically. But you get what I mean. If we didn't create these numbers through the process we did, we wouldn't know this would be an issue in Canada, and we can't deny it now. So I think the move forward is very clear. We've been really lucky with funders and other agencies to work with, and now we're into the transactional elements of this project. How do we take these findings and do something good for society? And that's going to be more work, but that's kind of what we feel is important to do for populations like this.
Yeah, and I sometimes wonder, like, we almost need to have a training session for all of the service providers and volunteers within the homeless sector to sit down and listen to you two and others, the others that you work with, to take people through this so they not only have an awareness, but they're now able to spot it, right? And refer and do the other things that need to be done. Do those kind of things happen after you finish a paper like this?
Well, our community partners are our goal. Like we can't do our studies without our community partners, and so we certainly give feedback to them and have discussions with them. Even when I did the community forums across the country, giving the results that we were learning thus far, we didn't have this paper out, but I did identify the greater range of neurodiversity. But I think if we're going to do training and look at an instrument, it would also be important to evaluate how helpful that is or what else needs to be done. Like if you refer and identify the problem, or like if you identify a problem but no one will step in to help, it won't be enough. So again, with these suggestions, we have to evaluate the usefulness of the suggestions.
Richard and Cheryl, our time is up.